ఓకేనా
ఇక్కడ ये भी ये हाँ जल्दी से बना के देता हूँ। कितने लेक्चर लिया मैंने? स्टार्ट हो गए? स्टार्टेड? हाँ good afternoon students. Today we will be considering 2010 long questions in general surgery. To start with, the questions are simple. First two questions belong to paper 1, that is general surgery, and rest of the questions, that is 4, they belong to systemic surgery. In general surgery, always remember you will have something from the shock, you will have something from the burns, you will have something from the wound healing. So these are the mainstay, and also congenital anomalies. In general, systemic, pancreas stands first, gallbladder, stomach, urinary bladder, then related to the carcinoma of the kidney. Okay, today first we will consider the septic shock. This question is very simple. Define and classify shock. This is always to start with. They may ask any specific type of shock, but this definition and classification of shock will be always there. So you should be thorough with the definition and classification. After that, we'll go for the septic shock in particular. So what is shock? Shock is the most common cause of death in surgical patients. That means it is like the failure of heart. The shock itself is a terminal event, mainly in all the ICU patients and for us in surgical patients. What shock is? This shock is defined as a systemic state of a low tissue perfusion. So what will happen if the perfusion is less? Ultimately, it will lead to inadequate. The perfusion is inadequate for normal tissue respiration. We also respire, our tissues also require. For their respiration, the heart pumps blood or the required going back to that. For the oxygenation, going to the tissue is a function of blood, and that is affected in shock. So ultimately, it is inadequate perfusion for normal tissue respiration. And what it adds? Now remember, you have been told it is a lactic acid. Lactic acidosis because of anaerobic conditions. Oxygen is less. So what will happen? The whole metabolism has to be performed on anaerobic metabolism. And there it is the lactic acidosis which comes in play. What it does? It will differentiate or reduce the cell membrane permeability. That means the intracellular material going to extracellular, extracellular coming to intracellular. So that fine line homeostasis is affected. So this simple oxygen, simple shock is leading ultimately to the cell death. Okay, so this is regarding this definition of shock. And what we are dealing with septic shock. What is this shock? It is not because of a problem or shortage of blood or fluid. It is a vasodilatory shock. You have got everything to eat, everything well prepared, but you don't have appetite or your stomach is dilated, so you cannot take anything. That is how the terminal vessels, terminal artery veins are dilated because of septic shock, and that is leading to the inadequacy of a tissue perfusion. In cardiogenic shock, there is no blood supply. In thrombosis, there is no blood supply. In hypovolemic shock, there is already shortage of fluid. But here, it is the dilatation. It is called as a vasodilatory or a distributive shock. Okay, you understand distributive shock. So, what are the classification? This I think you must know by heart. 5 only, simple. Hypovolemic, cardiogenic, obstructive, distributive and endocrine. Okay, these 5 should be on your fingers, 5 fingers. Hypovolemic means hemorrhagic or non-hemorrhagic. For us it is most common. Cardiogenic heart disease. Obstructive, there is no load, preload, that means the blood flow to the heart is reduced. It is cardiac tamponade or tension pneumothorax. Distributive, what we are dealing with septic shock or neurological shock, that is anaphylactic shock. Endocrine, there is always a problem in all the internal mechanism. What it occurs in hypothyroidism and adrenal insufficiency, that is Addison's crisis. Okay, so this is the definition of shock. Causes, very simply remember, hypovolemic shock, it is due to reduction of total blood volume. It can occur due to what? Hemorrhage, burns, peritonitis, vomiting. Cardiac causes, infarction, acute carditis. This cardiac cause can be drug-induced toxemia and surgical condition. There can be cardiac compression, again like cardiac tamponade, or trauma to heart, rare. Third is septic shock. Septic shock is due to bacterial infection. What it does? There is a toxin. The toxin released by the organism cause dilatation of a peripheral vasculature. Okay, these are three. Neurogenic. Neurogenic shock is to sudden, anxious or painful stimuli. The classical example is shock due to pressure over the testes. If you press or there is a trauma over testes, patient suddenly goes into neurogenic shock. Spinal cord injury. Anaphylactic, everybody knows it is a type 1 hypersensitivity reaction. The causes of a pressure over the heart or inadequate supply to heart are just respiratory causes like flail chest, thoracic injuries, tension pneumothorax. This is very important. That is why tension pneumothorax has to be treated immediately. You don't have a time. We must put a needle in second space now. Initially, in children, in adult, you have to put needle into fifth space. That is just inframammary. Respiratory causes are many times because of anesthetic complications. Other causes are, you can say, adrenaline, Addison's and mixed edema. Primarily 5 causes. Okay. Now this red line, if you remember this, you are through regarding the shock question. Simply, first 2 pages you remember. Best parameter to monitor or guide for tissue perfusion, adequate or inadequate, is urine output. Remember, blood pressure is maintained for a long time till it falls only after loss of 30 to 40% of circulatory volume. Till that time, patient maintains his homeostasis. Hypovolemic shock presents as low BP, tachycardia, acidosis and oliguria. In fact, all the shock present like this. Now coming to our specific question today, it is regarding septic shock. As I understand, you have been told about sepsis in your morning medicine lectures in detail. The basic cause of sepsis has been dealt by the medicine. What we are here is to find out the surgical cause and surgical management. Okay. Ultimately, septic shock is the commonest cause of death in all ICU or ICCU patients. Okay. So, in our surgical world, we don't go into details of the drugs. What is pathophysiology shock? It is a vasodilatory shock. Okay. And what is a SIRS? It is a grade 3 SIRS. That means systemic response to infection is grade 3. 3 stages: sepsis, severe sepsis, septic shock. We are dealing with septic shock. It is when there is a significant drop in BP leading to heart failure, stroke and organ failure. Remember, for a sepsis to go into severe sepsis, there has to be at least one organ involved. More organ involved, septic shock. Ultimately leads to MODS and death. This is regarding the infective cause. But there are major non-infectious systemic response. What it is? Acute pancreatitis, and this type of shock in burns by the toxins themselves. Understand? Hypovolemic shock is there in burns, but in low burns, in deep burns, even if quantity is less, the toxins cause this type of septic shock. Risk factors: answer is old age, prior illness, newborn and pregnancy. Associated causes: HIV infection, major surgeries, diabetes 1 and 2, and chronically hospitalized patients. Why so? Prolonged exposure for your IV line, intragastric tube, and associated poor nutrition. So these points define the septic shock. Next page. Investigations. Write down simply. All blood investigations, CBC, blood sugar, serum bilirubin, urine culture and sensitivity. This is common for any disease for that matter. Why blood culture and sensitivity? Told in the morning, because of a choice of antibiotics. But we do not wait for culture sensitivity report which takes 48 to 72 hours. We have to start a specific or broad spectrum antibiotic depending on the condition. Investigations: X-ray chest, USG abdomen, CT, MRI. Why so many investigations? You have to go for the cause. Okay. Now it is septic shock. What is the treatment? Very simple. First line treatment: aggressive volume expansion, because it is a failure of a volume. The choice of fluid is crystalloid, that means ringer lactate, and restoration of arterial oxygen. That means every patient of shock has to be given nasal oxygen, and not responding, go for ventilation. This is primary. Secondary: supporting the patient in bad period. What we are doing? Ionotropic support like dopamine. Today sir has given you so many names. We will remember only dopamine. Or adrenaline, NORAD. NORAD is very commonly used. Or sometimes vasopressin. Nowadays, high dose of activated protein C, that is APC. For all patients, it is very beneficial, but unfortunately very costly. Next comes in the line, plasma expanders. What they are? They are colloid. Colloid means albumin hemacin, that we can give for the patient to expand the volume, because those maintain the fluid volume for more than 4 to 8 hours. Crystalloid, very short period. This is the difference between the crystalloid and colloid. And mainstay as a surgeon, apart from antibiotics, find out the cause and go for the drainage, surgical drainage and debridement. That means whenever dead tissue is there which is causing this septic shock, you have to debride it. So this we have actually solved the whole question of a septic shock. Remember these two red pages, you are through in septic shock. Now we'll go into slide details. Okay. So what is a pathophysiology? Here, septic or vasodilator shock, it is a systemic response to infection. That means SIRS. Non-infective causes: burn, anaphylaxis, pancreatitis, adrenal deficiency, metabolic lactic acidosis, and sometimes you find carbon monoxide poisoning. Where does it occur? Carbon monoxide either intentional, that means somebody introduced, or it is in cases of fumes. Okay. And how do you measure the severity? The shock severity depends on what? Whether the shock is compensated or it is decompensated. Simple to place. Compensated means body has got adequate response to maintain blood flow to the kidney, lungs and brain. That means the blood supply to the vital organs is maintained. What are the signs then? Simple tachycardia and more important, cool peripheries. If a patient in your ward, the extremities are showing coldness, be cautious. Why it is? Because the compensation to the brain is maintained at the cost of skin. So the poor skin is sufferer for the heart and brain. Then comes the compensation. What it is? It is the next stage where the blood loss is more than 30 to 40%. And blood pressure will fall only after 30 to 40% volume is lost in the periphery. Okay, this is decompensation. Next comes, what are the stages of shock? Septic shock. Simple. Sepsis, severe sepsis, septic shock. What is sepsis? Whenever the infection has reached the bloodstream and inflammation in the body, this is sepsis. Any organism reaching the blood, that means pathological organism reaching blood, causes sepsis. Severe sepsis, This has affected one or two of the vital organs. And common vital organs affected are, for us, it is the brain, heart and kidneys. Light affection, but it is there. More bad is the septic. Drop of BP, heart failure and multiple organ failure. Okay. And septic shock is the most common ICU mortality. So what are the symptoms we should not ignore? Remember, temperature more than 101 Fahrenheit or 38 degrees. Never take the percentage temperature lightly in the ward admitted patient with some another pathology, as well as exactly against it hypothermia. Hypothermia probably is more worse sign. Never take it lightly. Low body temperature and tachypnea, tachycardia. These are all basic signs. The moment you see the patient, you must have a look at his respiration. How the respiration? What is the laborious? What is the rate? Simply, and put your hand on the pulse. What it will tell you? It will tell you the pulse rate, and also you get an idea about the temperature. So never ever miss for putting hand on the radial pulse. Whenever you talk with the patient, your fingers must be on the radial pulse. Okay, this is the basis of examination. So what is the septic shock? This is mainly due to organisms. Positive, negative, fungus, virus or protozoal, any origin. Even if there are secondary organisms occurring in the septic shock related to small intestine, strangulation. Strangulation also called the endotoxic shock. This is the mode of death in strangulation. Particularly we are dealing with the embolization, strangulation of the intestine. All cases of peritonitis, all cases of a major diabetic wound, and for a surgeon, major crush injuries lead to septic shock. Okay, and gram positive means exotoxin by gram positive bacteria. What are the commonest? Clostridium group. It is very bad organism. Either tetany or Clostridium velshae. Velshae causes what? Gas gangrene. Tetanus causes tetanus. Fluid loss, hypotension. For gram positive. Gram negative, this is endotoxemia affects urinary, gastrointestinal, biliary tract. All things are because gram negative is probably bad than gram positive. Because in gram negative, fever may be comparatively less and the toxicity is very fast. So two causes, positive, negative. Okay. So what is septic shock? This page will give you idea about the details. Common causes, biliary, urinary, GIT, respiratory. Common organisms, E. coli, Klebsiella, pneumonias. This is what we are talking. Okay. And the Clostridium, the king of all organisms. Physiological release of toxin, neutrophil, all of them, leading to what? SIRS, MODS. There are two clinical stages. You must remember this. First is hyperdynamic and another is hypodynamics. This is a type of circulation. You have to find out the source by USG or CT. All the cultures, antibiotic immediately started. Strict monitorization of the patient and ICU management. Treat the causes. Cause you have to find out and treat. This is the only way. Okay. So this graph also gives you what is a compensated, mild compensation, moderate decompensation, severe decompensation. This is regarded true for all types of shock. Lactic acidosis increases, urine output decreases, consciousness level decreases. From normal, it will go to comatose patient. Respiratory from normal, it will go to labored breathing. Pulse rate, where there is a mild increase in compensated, it is vastly tachycardia in severe decompensation. Blood pressure, normal in compensated, even mild compensation, but ultimately leads to severe hypotension. And then it is the end of story. It is a MODS, multiple organ failure. So you should not allow any patient go into decompensatory phase. That is the aim of management. Let the patient improve only in compensated stage. That means early diagnosis of a pathology. So what is pathophysiology? We have considered everything. Reversible is warm stage. Irreversible is a cold stage. Simple. If the patient is warm, he is in patient has got the chances of improvement. If the everything extremities are cold, low temperature, it is irreversible. Okay, this depends on the release of the toxin. Stages: hyperdynamic warm, hypodynamic is a cold septic, irreversible sign. These are the details. You remember only patient should be treated properly at this stage. That means when as long as it is reversible, you reverse the patient. Active management is required in reversible stage. Okay. So this is reversible, hyperdynamic and hypodynamic irreversible. This is the beautiful picture which shows how the types are divided. Cardiogenic shock. What happens? It starts from the heart. Reasons are extrinsic. Extrinsic means whenever there is a pressure over the heart. Cardiac tamponade. When it occurs into massive this pericardial effusion or tension pneumothorax. Okay, heart is compressed. Second is intrinsic cause of the heart like failure and ischemia. We are talking of a bacterial endocarditis or maybe acute myocardial infarction. Next cause is hemorrhagic or hypovolemic, where there is actually less volume in the blood in the body. From 5 liters, it is coming down by 3 liters. That goes to severe shock, more than 40% loss. Last is at the terminal end. In the end, that means where there is arteriovenous anastomosis. Terminal part. It is called as a distributive shock. It is a failure of distribution. That means everything is available but not properly distributed. So it is called as a septic or neurogenic shock. Okay, what are the treatment guidelines? Remember only guidelines. Treat the cause, improve cardiac function and improve tissue perfusion. These are the aims of the treatment. And how do you treat it? Stabilize the patient, evaluate the patient and then treat a specific cause. First stabilization comes, evaluation, treatment. Stabilize, evaluate, treat. This is the basic of a treatment of shock. So what is the early stage? Correction of fluid, treat the cause, that means drain the abscess, laparotomy for peritonitis. So at the same time, antibiotics according to the culture or the organ affected. Critical care, ventilator support, monitoring and add short-term high-dose steroid therapy. Those steroids are blamed many times, sometimes they are life-saving. And this is one of the conditions, the shock, where a short 1 or 2 dose of steroid is always warranted. Okay, so this picture also very simple. You just remember it. Again, you are getting distinction. Treatment of septic shock. First line of treatment: aggressive volume expansion with crystallized solution and restoration of arterial oxygen with what? Inspired oxygen or ventilation are the highest priorities. Second line, inotropic support like dopamine, noradrenaline, adrenaline and vasopressin. And dobutamine if arterial pressure is normal. Okay. High dose of C-reactive protein. This is mainstay for survival with severe sepsis and septic shock recently available. Plasma expander has to be used fully in septic shock associated with peripheral vasodilation. What it causes? Peripheral vasodilation is causing reactive hypovolemia. That means volume is there, but it has gone into reaction. So plasma expanders, what they do? They will hold the volume for 4 to 8 hours. Okay, so that is the treatment. And antibiotic surgical drainage, all investigation must be done to find out the infection. This is the simple table. You are through in the treatment of a septic shock. Okay. Now we'll come to question number 2. This question mostly asked for a short note, but here asked in the detail. You should have some idea about this pathology. And this pathology deals with what is called as melanoma. Etiology, clinical features, diagnosis and management of malignant melanoma. We don't come across melanoma very commonly, but this is one of the most common tumor in whites. It is 20 times more common in white race as compared to black race, even semi-black like ours. Okay, what it is? It is a malignant tumor arising from epidermal melanocyte, and it is a most aggressive cutaneous malignant tumor. Okay, and from where it arises? It arises from neural crest in development, that is a ectodermal in origin. Where they are commonly found? Head and neck 25%, trunk, almost to be frank enough, this is universally distributed. Head and neck, trunk, lower limb, upper limb. That means you can find it everywhere. And unfortunately, this is a leading cause of death in women. Very common cause in 20 to 39 years. So ultimately, what are the risk factors? So risk factors as usual, it is family history, past history. I think family history stands more important for any malignancy. Almost 20% of malignancies do have a family history. So it is always intelligent to ask the patient regarding his family history. Okay, it is very important. You should always ask. Okay, then dysplastic novi, HIV, cyclosporine. That means all immunocompromised patients, they are prone to develop malignancy of melanoma. The question is, what are the types? Simply remember two types: superficial spreading of malignant melanoma and nodular melanoma. Superficial spreading is 70% common. Nodular is second most common, 16 to 20%. Superficial is most common in white population, and it arises in dysplastic nevi. That means it was already there and now it has gone into malignant change. Most common site in males, it is trunk. In females, lower leg and back for a superficial spreading. Nodular, it can occur anywhere. It is more common in old age. You must find old age people having a very dark black spot over their face because it is common over head and neck. The difference between these two, it is only vertical growth and no radial spread. As against superficial spreading, it will spread radially. So what has happened? The nodular melanoma has got a higher risk and a poor prognosis. Reason is they are growing vertically. That means they have more depth as compared to superficial spreading. So this is regarding types. If you want to remember, there are different types. They are acral lentiginous melanoma. This is, we see more commonly, palm, sole, subungual and mucosal surface, in the face also, in the mouth also. But unfortunately for us, it is common in dark skinned. That means this cancer is our cancer. And because of its location, subungual, submucosal, it is late diagnosed. What is subungual? This is one of the most interesting or painful, because this type of malignancy arises in a dark skinned people and at a nail matrix on your finger, just finger. You can see it but can't do anything. Most common, grade 2 or thumbnails, means most important part. Do you know that the amputation of a thumb, for information, never forget this, what you call as a disability. Amputation of thumb is 100% disability for a certificate purpose, because without thumb you are nobody, thumbless. Okay, so this is great and thumb. Diagnostic is biopsy and it can extend laterally. Lateral fold does increase. Okay, then lentigo melanoma, common in face, old age. What you can't, but fortunately it is a low grade malignancy. So we know the types of a malignant melanoma. Risk factors, as we discussed: exposure to sunlight, ethnic factors, high society more common, surprisingly. The poor people are spared, unfortunately. Albinism. Albinism, everybody knows. White shade color, there is no melanocyte, but there also this is very common. Xeroderma pigmentosa. Commonest in junctional nevus. Second common is large congenital nevi, wherever they are larger than 20 centimeter. Okay, family history of melanoma is many times available. Patient may be unfortunate to have earlier skin cancer of a different types, and now he has got melanoma. That means similar history in the past, you can suspect melanoma and immunosuppressive patient. Why immunosuppression word comes every time? Nowadays, renal transplantation is commonest performed surgery in transplantation, and in that, patient has to take immunosuppressive drugs for the remaining lifetime. So what are you going to do him? Your lower this immunosuppression makes him more prone for malignancies. You lost one disease and you are added one disease. So take precautions. So what are the clinical features? Simple. Any age, 50% arise on the normal skin. Okay. And one thing, it is again in red pencil, melanoma is unknown before puberty. MCQ always write down, melanoma do not occur before puberty. And induration is not seen in melanoma because this is not inflammatory. Induration is sign of inflammation. Irregular surface, ulceration, bleeding and itching. Itching is more very painful in case of melanomas. Even for any nevus, whenever there is the itching started, think of progression to malignancy and change in color. So, in the graph I have written, what are the features of malignant melanoma? A, B, C, D, E, F. Okay. A stands for asymmetry. B for border irregularity. C, color variation. D, diameter more than 6 millimeter. The moment 2 to 3 millimeter mole is going to above 6 millimeter, think of a malignancy or malignant melanoma. Elevation of the swelling, enlargement swelling, and F stand for funny looking. It looks so odd on your face. It is a funny looking A, B, C, D, E, F. And prognostic factors are depth, ulceration, and lymph node status. I think they are everywhere. For any pathology, these are prognostic factors. Common site, extremities. Prognosis is good. In females, prognosis is good. Good prognosis. Histopathologically, lentigo maligna, good prognosis. So these are the prognostic signs. First is the features of malignancy, another is the prognostic factors of malignancy. Okay. What investigations you will do? Again, red line. No incision biopsy. Incision biopsy is not done because it may cause early blood spread. So what is the diagnosis done by? Excision biopsy. And what is the principle? The excision biopsy has to be done from 2 millimeter margin from the along with the deeper fatty tissue. Don't give a chance. Okay, 2 millimeter margin. Preferably punch biopsy in pinna, eye and nose. Punch biopsy of the eye, very difficult but it must. And nose, that means head and neck, you have to go for punch biopsy. What it assesses? It assesses the depth and thickness of the lesion. Where you should do? At the most elevated part. FNAC should be done for lymph node. Second is seen by USG. Chest X-ray for cannonball appearance. And HRCT, what is the commonest buzzword of today, is ideal for secondaries in chest. And secondaries are called as cannonball. Whereas this occur, the cannonball also occurs in chest in renal malignancies. Next is the again short note question is asked already. Breslow's thickness as opposed to Clark's level. So in malignancy, it is based on thickness of invasion. Thickness of invasion by optical micrometer is a Breslow's thickness for malignant melanoma. Stage 1 less than 0.75, stage 2 0.76 to 1.5, stage 3 1.51 to 4 millimeter, and anything above 4 millimeter is grade 4. That means malignancy has expanded. As against Clark level, level 1. This is pathological classification. Only epidermis, into papillary dermis, up to junction, intrareticular dermis and expansion. Whenever it extends the subcutaneous, it is level 5. So remember Breslow's thickness levels. So this graph, if you have time, go through it, which shows the different types. On one side, Clark's modification, another side it is Bresler. Okay, these are the different ways. Now comes the mainstay. What is the management? Now you are diagnosed, everything is done. What is the treatment of choice? For all practical purposes, surgery is the treatment of choice. For primary, what is called as a Handley's wide excision, wide local excision, and WLE. This is wide excision with clearance of margin as well as depth. So this is a wide excision is a treatment of choice. So what is wide? If the swelling is more than 1 millimeter, you have to dissect 1 centimeter. See beauty. 1 millimeter, dissect 1 centimeter. Okay. 2 millimeter, dissect 3 centimeter. But if it is more than that, it is ultimately 3 to 4 centimeter. So 1:10 is the routine ratio. And if suppose the primary of the extremity is wider than this, the ultimate solution is amputation. And unfortunately, amputation has to be one joint above. In finger and toes, it is a disarticulation. Melanoma of anal canal, very simple, looking small black spot at the anal verge. The treatment is abdominoperineal resection. Understand? So such a fast growing malignancy, and if the patient is blind with some other amputation of the joint, the diagnosis is melanoma. A blind patient with amputation of toe, diagnosis is melanoma. Always remember, because the treatment of any melanoma of the eye is enucleation. Unfortunate part, but many of the patient has got two malignancies, eye malignancy plus finger malignancy. And very bad in pregnancy has to be terminated. Is the treatment of choice for pregnancy. And also what is the advice? Postpone the pregnancy for another 2 years. So simple melanoma, no pregnancy for 2 years. Okay. And regarding the lymph node secondaries, general. Moment you get FNAC positive lymph node, the survival, 5-year survival reduced to 50%. Fixed lymph node, only chemotherapy. For distant pressed, again chemotherapy. That means for all secondaries, chemo and immuno are the mainstay of the treatment. Radiotherapy can be useful for bone and brain secondaries. Again, as a general knowledge, I tell you, commonest brain secondaries are from melanoma. Okay, just write down for MCQ. So what is it is? The now advanced of the treatment is, because even if it is small, the science is bound to progress. For distant pride, chemotherapy and immunotherapy is the main treatment. And what it is for a brain secondary, it is a gamma knife now available for removal of brain secondaries in melanoma. For frankly speaking, everywhere gamma knife is the buzz of today. Then comes what is local treatment, that means of the extremity. Wherever amputation we want to avoid, because amputation is the only answer, where we can try for laser ablation of multiple small cutaneous lesions. And for a short note, remember it is called as isolated limb infusion. If you have time, you can go from this figure. It is from the book. Isolated limb perfusion. Indication, lesions of the extremity and unresectable recurrences. Multiple transit metastasis. And what we are doing is a hyperthermic infusion. These days, HIPEC is a treatment of choice. HIPEC is a hyperthermic infusion in the abdomen. That is HIPEC. Hyperthermic infusion in the leg. And what we are doing is induction of with melphalan drug, tumor necrosis factor. Everything is there, and isolated limb infusion can be tried with the hope that amputation can be avoided. But few people say not much improvement, but this is science. Everything available must be tried for every individual. Okay, so we have finished 2 questions. One question I will try to finish today. Commonly asked, this is important from practical point of view, from short note and long question. Very commonly asked. What is the question? Discuss obstructive jaundice, its investigations and management. Looks so simple. Oh, obstructive jaundice. But the moment you start writing, you are confused. What should I write? Because jaundice means infectious hepatitis. That is, you are taught so many times in medicine. Commonly, we come across infectious hepatitis. Surgical, comparatively rare. So, what is the definition? It is the jaundice that develops due to biliary obstruction. This obstruction can be partial or complete or intermittent, and it causes conjugated hyperbilirubinemia. This is definition of surgical jaundice. Okay, it is a conjugated. What is the normal serum bilirubin level? 0.2 to 0.8. When you develop scleral icterus, when it exceeds 2.5 milligram per second. That means practically all patients coming to us with surgical jaundice have got more of a serum bilirubin above 2.5 milligram. Enlargement of liver. In all cases, what it is called as hydrohepatosis. This is a part of surgical jaundice. In the biliary tree, what is there? Cholangitis. Cholangitis is an inflammation of the biliary tract. Next comes vitamin K absorption is reduced. Very important. And what it causes? It causes fall in PT-INR, prothrombin level, and INR. PT-INR is fallen. That means chances of bleeding. PT-INR is routinely done now for every surgery. And retention of a bile salt and bile pigment in a blood and body fluids. What it will do? It will give rise to yellowness of all over body, including tongue, mucosa, hands. This is because of a bile fluid. This is in short the definition of a obstructive jaundice. If you remember this page from the book, you know all the causes. Question was causes of surgical jaundice. Simply remember the figure. What it is? Biliary atresia. Colorectal cyst. We are starting from above. From where? From the base. Biliary atresia means in the liver itself. Colorectal cyst in the common bile duct. Ascending cholangitis, inflammation of bile duct. Biliary strictures in the bile duct. Sclerosing cholangitis, sclerosis means thickening of the gallbladder, CBD, common bile duct. Then comes malignancy. What are they? Carcinoma of the head of the pancreas or carcinoma of the periampullary region. That means two carcinoma. CA carcinoma of the head and CA periampullary carcinoma. Cholangiocarcinoma. What it is? Carcinoma of the bile duct. And then the carcinoma of the hepatic duct at the confluence. And what tumor is called as? Again important, never forget for short note. It is a Klatskin tumor. Klatskin tumor is a confluence tumor arising at the confluence of a hepatic duct. That means at the junction of a left and right hepatic duct, the Klatskin tumor arises. And Klatskin tumor excision is a very major surgery, ultimately landing into liver transplantation. So these are the important causes of a surgical jaundice. Okay, this is not so simple. And for us practical purposes, commonest cause is CBD stone. For us, CBD stone is the commonest cause. Next common cause for us in our practice is carcinoma head of pancreas and periampullary carcinoma. These are the for us. Klatskin tumor, you have to remember, no choice because of a short note. Okay, so clinical features. How does the jaundice, that means surgical jaundice, present to us? It is a severe jaundice, first of all. Second, most important, this jaundice present with pruritus. Infectious hepatitis, pruritus is not there. Surgical jaundice, pruritus. Where does it occur? Back and forearms. Fever may or may not. Now, again red pain, loss of weight, loss of appetite, and pain in the right hypochondrium and palpable gallbladder. This is a very important and discussion required for this side. Liver palpable. Many times liver is non-tender, smooth and soft. That means liver per se has got minimum role to play in surgical jaundice. Though everything is produced in the liver is putting silently. It is the obstruction on the road, not on the vehicle. Vehicle is good, but the road is bad. Okay. And now, always taught to you for a short note long question, Carvajal's law. Carvajal's law state what? Is suggest the cause of obstructive jaundice as an inflammatory or neoplastic. Then Charcot triad or pentad. They are all presentation of a cholangitis. Most important sign for jaundice is steatorrhea. That means because of improper absorption of fat, the stools are fatty. Okay, that is steatorrhea. Steatorrhea with weight loss goes in favor of a carcinoma of the head of pancreas. Now, this is a different classification. I think it is very difficult to remember, but just we'll go through it. It is a Benjamin's classification for a biliary obstruction. As obstruction we have discussed, either it is a complete obstruction due to tumor, it can be intermittent obstruction due to cholelithiasis or a periampullary tumor. This is intermittent. It can be chronic complete. First is complete, intermittent, chronic complete. No malignancy, but it is a duct stricture. It can be congenital or it is a traumatic. Very common, and fibrosis or chronic pancreatitis, where there is a complete obstruction of any part of a bile duct CBD or the total chain. Last is segmental. Segmental can be because of trauma or because of a cholangiocarcinoma. Only part of the biliary tract is involved. Complete, intermittent, chronic complete and segmental. These are the four classifications as per the Benjamin. Okay. And how are we going to investigate? Now you know that there is jaundice. How are we going to do? First is serum bilirubin. Direct and indirect both required. Direct is resin conjugated. That means in obstructive jaundice. The blood test or urine test is Vanderburg test is done. Serum Ag ratio, that means albumin globulin ratio. Normally serum albumin is more than 3.5 grams. If it is less, PT, prothrombin time, normal value 12 to 16 seconds. Prothrombin time will be grossly enlarged. What it is when you say significant, it should be more than 4 from normal. That means anything above 1 minute of PT is in favor of obstructive jaundice. Or in a control, it should be 1.5 time of the control. Okay. Then all the blood investigation, SGOT, SGPT, total count, USG abdomen, ERCP done previously, but now the treatment of choice is MRCP. Whenever it fails, ARCP fail, you have to go for a PTC. PTC is a percutaneous trans-liver biopsy, cannulation. That means cannulation is done directly to the liver. And PTC stenting is across the obstruction under the CR. So these in short are the investigation. Okay. Other investigation of choice today is MRCP. Why? It is a non-invasive diagnostic tool with 96 to 95%, 99% sensitivity and sensitivity. Tumor marker. These are the buzzword of today. Tumor marker. Remember only one. C19/9 for a carcinoma of pancreas. Forget the rest. Identify involvement of portal system, CT, MR angiogram and venogram. So many tests. For a bile segment, everybody knows it is a Fauci test, Hayes test for bile salt and test for urobilinogen in urine. This you are taught in your physiology or biochemistry, whatever it is. So you know all the urine tests required for obstructive jaundice. After investigation, most important obstructive jaundice is a patient preparation, because these patients are very risky to be operated. So how do you prepare them? Pre-operative preparation of patient with obstructive jaundice. Again ask for a short note. First, proper diagnosis. Second, equally important, pre-operative injection of vitamin K. Okay. Then comes FFP. Remember, all these patients are very bad patients, grade 4, 5. So preparation is a must. Fresh frozen plasma, that is FFP. Many patients require more than 6 bottles of APP. Why? Because of maintenance of a coagulation factors. Hydration, blood transfusion, neomycin orally. That means you have to clear the gastrointestinal tract. For that, many are also given for hepatorenal syndrome. Daily PT, electrolytes, antibiotics, calcium, and preoperative decompression. What it is? Many of the patient has got bilirubin more than 12 milligram. Their decompression of the gallbladder has to be done. How you will do it? You will pass a ERCP stenting. This is preoperative decompression. Coagulation correction. So this is the mainstay of a preoperative management. And what is the treatment? Treatment is simple. CBD stone, ERCP stone removal. Carcinoma head of pancreas periampullary, we pulse operation. We have discussed it is a triple bypass. Biliary stricture, stenting. Klatskin tumor, our favorite tumor at the left and right hepatic duct, it is a radical resection. Not possible, then palliative stenting. For a biliary atresia, it is a Kasai's operation or a liver transplant. Kasai's operation for biliary atresia. This is very difficult operation. You have to give a posterior layer. Colorectal cyst, excision. And pruritus. This symptom is very severe. Why this occurs? Due to retention of a bile salt which activate the release of histamine. Treat the primary, the pruritus may be relieved, but it is very difficult to treat. You should pray the God that his pathology is earlier reduced. And drugs available for this are cholestyramine. Drugs are useful for management of pruritus. Again, going like this corticosteroid. They may help in management of pruritus. Okay. So sometimes we have to go for what? Choledochotomy. Apart from management of the pathology, you have to go for choledochotomy. Choledochotomy is removal of a stone from a common bile duct. That is called as a choledochotomy. What it is? Whenever USG is showing stone in CBD. Remember, stone CBD diameter more than 10 millimeter is very significant. This shows that there is some impaction in CBD. Jaundice history with raised alkaline phosphatase. On table now not done nowadays. Previously it was done because now with MRCP you know everything by beforehand. But if suppose there is a failure of a ERCP, prior to cholecystectomy, you have to go for choledochotomy. So this is short note on choledochotomy. That means incision taken over the common bile duct. So postoperative management, prothrombin time, creatinine, electrolyte, blood transfusion, antibiotics, associated all things. Care of T-tube, drains, T-tube cholangiogram was repeated previously, not done now. It is done after 10 to 14 days. And what this patient requires is a total parenteral nutrition, nasogastric tube and urinary catheter. So this we have finished regarding what is the obstructive jaundice. So this is a small question, this we will also finish. So what it is? Discuss carcinoma esophagus and management. Again ask question at least for short note. In esophagus commonly asked is Barrett's esophagus, Boyer-Weiss syndrome and carcinoma of the esophagus. This will go very short. Remember key points of a CA esophagus. Most common CA esophagus is squamous cell carcinoma. Always write down. In higher countries like United States, Western countries, common is adenocarcinoma. Why adenocarcinoma? Because it is resultant of a Barrett's esophagus. More common in males and most common site is middle one-third. Middle one-third what occurs? Squamous cell carcinoma. So this chart, go through it simply for 2, 3, 5 minutes and you will be master of esophagus question. Squamous cell carcinoma, adenocarcinoma. Everything is here. Squamous cell rarely seen before the age of 30 years. Adenocarcinoma infrequently seen below 40 years. That means squamous cell carcinoma occurs in younger age, adenocarcinoma in an older age. Highest mortality in men between 60 to 70 years of age. That means usually old age are suffering from carcinoma of the esophagus. In principle, esophagus is common in old age. Just write down that. Adenocarcinoma incidence is increasing with age. Longer you live, longer the chances of getting malignancy. So choice is ours. Adenocarcinoma more common in white men. Squamous cell carcinoma, African American. But India is equally common. So we are probably African. Adenocarcinoma, Barrett's esophagus. Barrett's esophagus you must study in detail because this is important short note and common condition these days because there is a 40-fold increased risk for adenocarcinoma. That itself goes in saying that you must know Barrett's esophagus. Adenocarcinoma common in lower one-third. Squamous cell carcinoma common in middle one-third. Now see the beauty. Obesity is protective in squamous cell carcinoma and obesity is a risk factor for adenocarcinoma. This you must remember. Risk factor in H. pylori, A strain, CAG A strain is a risk factor. As against that, the same factor is protective in adenocarcinoma. Difficult to explain, but it's true. Obesity protective for squamous cell, obesity risk factor for adenocarcinoma. CAG strain bad for squamous cell, good for protect adenocarcinoma. Okay, and squamous cell is a exophytic lesion with a large fungative mass, and that makes it more sensitive to chemoradiotherapy. That means aggressive treatment is with non-surgical therapy for squamous cell carcinoma. As against the adenocarcinoma is not sensitive to chemoradio and the only choice available is aggressive surgical approach for adenocarcinoma. Okay. So what are the clinical features? Early stages usually they go for asymptomatic or they mimic GERD. What GERD? Everybody knows by now. It is gastrointestinal reflux disorder. Common symptom dysphagia and weight loss. Most of the patient present with dysphagia and weight loss before anything. So patient old man is not taking food and losing weight. Always suspect CA esophagus. Sometimes there can be coughing aspiration, change of voice. Change of voice is also a sign of a CA esophagus. Also regarding the respiratory in advanced cases. Metastasis as usual liver, lung and bone. Investigation barium swallow. Endoscopy with biopsy is the investigation of choice for diagnosing CA esophagus. Endoscopic ultrasound EUS. Now it is very commonly done. This is regarding the staging of CA esophagus. So this investigation is the investigation choice for staging of a carcinoma and CACT abdomen. This is a TNM staging. Easy to remember. Whenever you get time, go through the chart. TIS high grade, T1 invasion of lamina propria or submucosa, T2 muscular propria, T3 beyond muscular propria, T4 invading adjacent structure, T4B adjoining structure like trachea bone. That means one stage ahead. N0 no lymph node, N1 1 to 2 nodes, N2 3 to 6 nodes, and N3 is number of nodes above 7. M0 no distant metastasis, M1 as usual distant metastasis. Okay, and this is a very simple graph for staging. Early stage disease, locally advanced disease. Early stage is T1, T1 and N0 or N1 at the most. Locally advanced T3 plus N1, N plus, that means N1, N2. Local therapy, upfront surgery for radiotherapy with increased mortality for early stage disease. Okay, preferred over early surgery. For locally advanced, the surgery is avoided. It is a neoadjuvant chemotherapy or neoadjuvant chemoradiotherapy for the tumor which is advanced in case of adenocarcinoma. For a squamous cell carcinoma, it is a neoadjuvant chemotherapy plus definitive chemoradiation. These are for the poor surgical candidates. That means good surgical candidate, it is a local excision. That means surgery is the treatment of choice. So this graph shows you management. If you have time, go through it. Management of a carcinoma. Tumor staging is done by barium swallow endoscope. Clinical evaluation. Late disease, early disease, intermediate disease, advanced disease. These are the four criteria. Chemoradiation, early disease, tumor to mucosa, transhiatal mini-venous surgery, en bloc dissection, chemoradiation. So just about all these graphs, remember if it is advanced disease, preferably go for a non-surgical management. If it is early disease, go for a aggressive surgery. Then comes supportive care. If it is not treatment failure or recurrence, supportive care, palliative surgery. Palliative surgery is the form of passing a tube. Endotracheal, this endoesophageal tube available this day. Less ablative, very short tumor excision therapy, passing of a stent, and whenever there is an airway fistula, that is a bad thing. Fistula between respiration and esophagus. And chemotherapy gives very good result. The surgery done here is transhiatal esophagectomy. There are two types of surgery. So treatment of esophagus in short. High grade endoscopic mucosal resection. This is the boon. Very good surgery. It is an EMR. This is OPD surgery where you can easily remove because esophagus has no sensation. It is done endoscopically. Localized esophageal cancer, you have to go for minimally invasive esophagectomy plus neoadjuvant chemoradiation surgery. Locally advanced chemoradiation. Metastatic definitive chemoradiation. Malignant tracheostomy fistula coated SMA, that is self-expanding metallic stents. Okay, this is a treatment pattern for a CEO esophagus. Now, if somebody wants to remember these two names: Ivor-Lewis two-stage procedure and McCowan three-stage procedure. These are the advanced procedure. Ivor-Lewis means subtotal esophagotomy done by 2 incisions. Three-stage done by 3 incisions. Okay, this is the major difference. And the percent, this is a better because the leakage is more, because major mortality occurs due to the leak. Leak percentage is more in 3-stage, comparatively less in 2-stage. But mortality less in case of 3-stage. It is a choice of a surgeon to do whichever indication. Okay, so this graph shows you what is a 2-stage and 3-stage. This is 1 incision, this is 2 incision. Here 3 incision. One is subcostal, one is intra-abdominal, another is in the neck. So this is how you differentiate. So last question, in short, we'll just take commonly asked, at least in short note, is what are the causes of hematuria and how do you manage a case of hematuria in man age 70 years. Hematuria is same cause everywhere. It is basically for hematuria of that means urinary tract is trauma, infection, malignancy. These three are the commonest cause of bleeding. If you write down trauma, infection, malignancy, you are through. Okay, then what is hematuria? There are basically two types nowadays. One is gross, another is microscopic. Gross means visible to unaided eye. Microscopic means 3 to 5 RBCs per high power field. And that is important. It should be on 2 consecutive occasions. Okay. Early initial hematuria, that means to start with, it is urethral origin. Terminal hematuria, bladder, neck or prostate. Total hematuria, bladder, UTI. False hematuria there. Because white occurs, it gives only red color. And the cause is from pigment from food coloring. Sometimes they can give rise to red colored urine and myoglobin. Whenever the converted hemoglobin is secreted, it gives rise to red colored urine. And silent hematuria occurs in malignancies, mainly kidney or bladder, unless proved otherwise. This is a dictum. So this graph is simple. A relation of hematuria to micturition and the site of bleeding. Blood appears at the beginning. It is urethra. Blood appears at the end. It is vesicle, that is bladder. Blood is intimately mixed throughout the process. It is prerenal, renal or vesicle. And in old age, it is a malignancy. Okay, you are sure about it? Again, go through this graph. This shows you what are the causes. This graph simply shows you causes. On one side, it is a malignant cause. In another, it is a benign cause. So, what are the causes? Renal injury, urinary stones, Wilms tumor, tuberculosis, renal cell carcinoma, cystitis. Bladder tumor, biliary bilharziasis. This infection is very bad, occurring mainly in African countries. BPH, CA prostate. Renal infarct, glomerulonephritis, and blood dyscrasia. So these 12 are the commonest causes of hematuria. Go through this graph, you will know everything. Okay. So these are the 12 causes. First is trauma, infection, malignancy. If you write down this, good. Types of hematuria in elderly, they are what? Gross or microscopic is visible to naked eyes. Microscopic, not visible to naked eyes. And when you examine this, what it should be? There should be absence of a sexual instrumentation or menses in case of females. And initial suspicion is confirmed with the dipstick examination. If it is positive, then only think. So not everybody should see for that. Causes in the elderly, blood in urine is a sign of underlying disease. Okay, and it should be taken seriously and investigated. So what are likely causes? UTI including schistosomiasis. This schistosomiasis body always come regarding the bladder. This is one of the cause of bleeding as well as a major cause for a carcinoma of the urinary bladder. Second comes malignancy. Bladder, urethra, kidney, and incidence is 88% in bladder and 40% are renal cancer present with hematuria. As against macroscopic hematuria may be the only sign of malignancy in old age. Next cause, ureteric renal stones. Fourth, nephropathies, that means kidney pathology proper. BEP, very common in old age. Radiation induced cystitis, that means patient taking radiation for other diseases, he can develop a major cystitis. Clotting disorders as hemophilia, inflammation of the bladder, prostate, urethra. Drugs. The drugs like rifampicin and cyclophosphamide. Remember rifampicin given for anti-tuberculosis. This gives you red colored urine. Never forget this. You must have been taught 100 times. Rifampicin gives red colored urine. Trauma. False hematuria is food pigment. And malingering. Patient many times malingering. Old age malingering is very common. They want their attention. And one cause, it is surprising to know, strenuous running. If you are not used for running, strenuous running can cause hematuria. This is new to me also. And how do you manage an old age? The management is simple. First, you have to find out the cause and manage the cause. That is the primary thing. How do you manage it? Must take a history in detail, physical examination, definitive history. Because history may be the only symptom. Ask regarding frequency, incontinence, change in the character of steam, and pain. Change in the character of steam goes in favor of BEP. Whether pain, the dysuria is there, because malignancy is usually painless hematuria. Dysuria is not there. And painful then, either a stone, infection, or a clot cooling. You also have to examine abdomen for any pain. If the patient says pain in abdomen with hematuria, it is probably clot cooling. Urgency. Urgency is a sign of inflammation. And whether the hematuria is continuous or occurs episodically, sometimes. Whether it is initial, terminal, or total. That means whatever you are studying, you have to ask the patient. And now important sign of a comorbidity. That is periorbital and pedal edema. This is regarding kidney. Whether the patient is taking nephrotoxic drugs, whether the patient will history of passage of stools, whether there is a BP, pellar edema, and one must go for PR examination for the prostate enlargement in males. Also see, never forget trauma. Trauma over back with bruising over the loin goes in favor of a traumatic bleeding from kidney, because kidney is quite superficial in the renal angle. Okay. So investigation, common. Culture, the urea test, USG, urothroscopy, IVU, cytology, BTCT, abdomen CT, and radiological imaging like USG, CT, MRI, IVU. IVU not done commonly now. Management is very simple. First is a management of pathology. That means all attempts should be done to find out the pathology and treat the pathology. Okay. What are the principles? The treatment depends on the gross or microscopic hematuria. What the principle says? Microscopic can be managed on OPD basis. Nothing to worry. Don't be afraid of it. Macroscopic is bad. These patients may need blood transfusion. What you should ask them? Encourage to drink plenty of water. There has to be free drainage of urine, no obstruction. You can give with catheter or without catheter. That is a patient's or your choice. And definitive treatment depends on the cause. Cause has to be found by detailed investigation. Okay. This comes to the end of 2010 question paper. I think you are getting some advantage by our lecture series of repetition revision. Thank you very much. Good day.